Welcome to the Surgical Educator's Advanced Online Operative Surgery Masterclass. Allow the words in the podcast to permeate into your mind. In this session, we are going to discuss the various operative steps in open cholecystectomy, along with excellent line diagrams, as if going through an operative atlas. Visualize the patient discussed in your mind's eye, or run a mental movie of the various steps of the surgery to have an indelible impression. By doing this mental rehearsal, you will experience an immersive and transformational learning experience and gain the much-needed confidence to do the surgery successfully. This will eventually result in achieving excellence in surgery. Thank you.
And it's truly a privilege to embark on this mental rehearsal with you today.
Yeah, absolutely. I mean, imagine staring into a surgical cavity, right? Navigating human tissues that are, well, inflamed to the consistency of concrete, knowing that like a single millimeter of miscalculation could sever the primary blood supply to a major organ.
Right, the stakes are incredibly high.
They really are. And today, we aren't just reading a textbook. We are basically scrubbing into an open cholecystectomy. So as we pull up slide 1 of our presentation to officially set the stage, our mission becomes clear. We are undertaking this highly intensive deep dive into a foundational procedure, and it's grounded entirely in the brilliant operative surgery masterclass developed by Dr. B. Selvaraj.
Yes, the renowned surgical educator from Coimbatore, India.
Exactly. So what's our goal here today?
Well, we are going to mentally walk alongside the surgeon. The goal is to unpack not just the what of each maneuver on these slides, but the crucial physiological and mechanical why behind it. We really want to transform these clinical bullet points into a vivid, applied understanding of human anatomy.
Because memorizing lists only gets you so far, right?
Exactly. When you understand the biological physics of like why an instrument is placed at a specific angle or the fluid dynamics that dictate why one type of knot is chosen over another, that knowledge permanently anchors itself in your mind.
Yeah, we are turning the theoretical into the highly tactical.
Yeah.
So let's get our hands washed and step right into the operating room. Advancing to slide 2 in our deck, we hit section 1, the blueprint and the setup.
The foundation of the whole procedure.
Right, because before a scalpel ever touches the skin, we have to understand the foundational why of the surgery and the meticulous preparation of the patient. So this slide lists 3 core indications for an open approach: symptomatic cholelithiasis, porcelain gallbladder or carcinoma of the gallbladder, and finally, failed laparoscopic cholecystectomy. Let's look at that first one. Symptomatic cholelithiasis, that's just the medical term for gallstones causing active problems. Right?
It is, yeah. But the word symptomatic carries a lot of weight there. I mean, many people have gallstones floating around in their gallbladder for their entire lives without ever knowing it.
Oh, really? Just asymptomatic stones.
Exactly. The gallbladder is a storage sac for bile, right, which is produced by the liver to digest fats. And sometimes the cholesterol or bilirubin in that bile, it crystallizes into stones.
Yeah.
But it only becomes a surgical indication when those stones start causing blockages.
Got it. So when they get stuck.
Right. When a stone lodges in the neck of the gallbladder or the cystic duct, the gallbladder is basically trying to squeeze against a closed door.
Yeah.
That causes biliary colic, which is this intense gripping pain.
Ouch.
Yeah. And if the blockage persists, the trapped bile becomes stagnant. And that leads to acute inflammation and infection, a condition called cholecystitis. That is when the organ, it becomes a liability and has to come out.
Makes total sense. Now, the other 2 indications on this slide, they seem to highlight why the open approach, like the traditional large incision surgery, is still so vital today, even in the age of tiny, minimally invasive cameras. A porcelain gallbladder.
Yes.
The name sounds delicate, but my understanding is that it's the exact opposite of delicate.
The exact opposite. The term is highly descriptive of how the organ actually feels in the surgeon's hand. Chronic long-term inflammation can cause the muscular walls of the gallbladder to become heavily calcified. It literally turns into a rigid, brittle, ceramic-like shell.
Wow, like a piece of pottery in the abdomen.
Precisely. And this is a terrifying environment for the delicate, tiny instruments used in a laparoscopic approach. You can't easily grasp it, you can't manipulate it, and it often just obscures the surrounding anatomy.
Right, you'd just be slipping off of it.
Exactly. And furthermore, a porcelain gallbladder carries a significantly higher historical association with gallbladder carcinoma.
Oh, wow, so there's a cancer risk.
Right. So if there is a suspected malignancy, the surgeon wants maximum tactile feedback, wide exposure, and the absolute ability to control the margins of the tissue they're removing. You just cannot achieve that level of control through tiny ports. You need your hands in the abdomen.
Which brings us to the 3rd indication here on slide 2, failed laparoscopic cholecystectomy. I imagine this is just a massively high-stress scenario, right? You start the surgery thinking it'll be a straightforward camera procedure, but something forces you to change plans.
It represents a critical threshold in surgical decision-making, though failed is perhaps a misleading term.
Really? What would you call it?
Strategic conversion is much more accurate. A surgeon might insert the laparoscopic camera and find that severe, repeated infections have basically fused the gallbladder to the liver, the intestines, and the bile ducts.
Just a giant mess of scar tissue.
Exactly. A thick, impenetrable block. Or there might be unexpected bleeding that just cannot be quickly controlled with laparoscopic tools. A master surgeon recognizes the exact moment when continuing laparoscopically transitions from being minimally invasive to being maximally dangerous.
Right, ego has to leave the room.
Yes. Making the decision to quickly and decisively convert to an open procedure, that is the ultimate safety net. It saves lives.
So you can't just be a lap specialist, you know? You have to be a master of the open technique for when things go south. Now, moving down the setup bullet points on slide 2, it specifies general anesthesia with an endotracheal tube, or JATT. The patient is in the supine position, flat on her back, utilizing an X-ray table, which we will get to why the X-ray table is important a bit later.
Yes, definitely.
But here's the physical detail that really fascinates me. The slide instructs the team to place a rolled towel or a sandbag in the right lower chest. Why?
This is, it's one of those elegantly simple mechanical solutions that totally predates high-tech surgical equipment.
It makes me think of like a stagehand in a theater preparing a set. You know, if you have this complex multi-level stage and you want the audience to focus on one specific actor hidden in the back corner, you don't just ask the actor to step forward.
Right.
Sometimes you physically tilt the stage or elevate that specific floorboard. So by placing that rolled towel directly under the right lower chest, you're using the geometric fulcrum of the patient's own rib cage and spine to push the target area up and center stage.
That's a perfect analogy. The body's topography is entirely malleable under anesthesia, and the liver is this massive, incredibly heavy, blood-filled organ that occupies the whole upper right quadrant of the abdomen.
And the gallbladder is hiding right under it.
Exactly, tucked snugly underneath it, almost hidden. So by arching the right lower chest upward with that sandbag, you are effectively hyperextending the spine slightly. This opens up the angle of the right costal margin, that lower edge of the rib cage.
So things sort of fall away.
Yes. You're recruiting gravity. You let the surrounding intestinal loops fall away inferiorly down into the pelvis, while physically pushing the liver and biliary tree anteriorly closer to the surface of the skin. It just makes the initial exposure a fraction of a degree easier, reducing the depth the surgeon has to reach.
Okay, so we have the patient perfectly positioned, arched upward, almost like an offering to the surgical lights. But before we make the cut, we really have to look at the bottom of slide 2. The informed consent and the associated risks.
Crucial step.
The numbers are staggeringly low, but also incredibly specific. Let me read them. Bile leak or biliary fistula at 0.5%. Peritonitis at 0.1%. Missed stone at 1%. Injury to the bile duct at 0.3%. Vascular injuries to the portal vein or hepatic artery at 0.1%. Abscess at 0.2%.
Yeah.
And then general injury to the liver, duodenum, or colon.
Right.
You know, when I see a number like 0.1%, human nature just kicks in and says, oh, a 1 in 1,000 chance, that's basically zero. Let's move on.
And indulging that cognitive bias is exactly how catastrophic mistakes happen in the operating room.
Really?
Oh, absolutely.
Huh.
These percentages are indeed incredibly low, which is a testament to over a century of refining this specific procedure. However, the anatomical gravity of the structures we're talking about demands profound respect.
Unpack that.
Let's take that 0.1% risk of vascular injury to the portal vein or hepatic artery. Mathematical rarity does not soften anatomical reality. The liver is the body's chemical processing plant. It requires a massive, constant blood flow. The portal vein delivers nutrient-rich blood straight from the intestines, while the hepatic artery delivers oxygenated blood from the heart.
So severing one of those isn't like, you know, nicking a capillary in your finger while making dinner.
Not at all. An injury to the portal vein is a massive, high-volume hemorrhage. Blood will immediately fill the surgical cavity, just instantly obscuring the surgeon's vision.
Which sounds like a nightmare.
It is,
Wow.
because when a surgeon cannot see what is bleeding, the panic instinct is to clamp blindly, and that often leads to crushing the nearby common bile duct or other vital structures. So a 0.1% risk means that if you perform 1,000 of these surgeries in your career, one day you will be faced with a sudden, potentially fatal hemorrhage that requires immediate, calm, life-saving vascular reconstruction.
Wow. So reviewing this informed consent slide isn't about, like, ticking legal boxes with a clipboard. It is a mental threat assessment for the surgeon.
Precisely. You have to be prepared for the 0.1%.
That perfectly frames the psychological stakes here. Okay, we have the why established. The patient is asleep and breathing through a tube. They are positioned over the sandbag, and the threat assessment is dialed in. Let's transition to the physical approach. Advancing to slide 3, we enter section 2, gaining access to the surgical field.
Time to make the incision.
Right. And the slide presents us with a fork in the road here.
Okay.
We have the right upper transverse abdominal incision, which the slide specifically notes is cosmetically superior, versus the right subcostal, widely known as Kocher's incision.
Yes, the two main approaches.
I have to admit, seeing cosmetically superior listed as a primary factor in a major abdominal surgery feels slightly, I don't know, out of place after we literally just discussed fatal hemorrhages. How does a surgeon actually weigh these two options?
It's a great question. The inclusion of cosmetic superiority actually reflects a very mature, holistic surgical philosophy. Obviously, the primary objective is unequivocally the safe extraction of the pathology. But a surgeon must also consider the patient's physiological and psychological recovery decades after the operation.
Okay, so how does the transverse incision work?
A transverse incision runs horizontally. It is designed to strictly follow Langer's lines.
Langer's lines. You mean the natural tension lines of the skin?
Correct. Human skin isn't just a uniform flat sheet. The underlying collagen fibers align in specific directional patterns. A transverse incision runs parallel to these natural collagen folds.
So it's working with the body.
Exactly.
Mm.
Because it works with the structural grain of the tissue rather than cutting across it, the wound experiences far less lateral tension as it heals. This typically results in a finer, much less noticeable scar.
Which is the cosmetic part.
Right. But it also often results in less postoperative pain for the patient because the abdominal muscles aren't fighting the direction of the cut every single time they take a breath.
Ah, so cosmetically superior is actually a byproduct of being biomechanically superior for wound healing. That makes total sense. So what about the alternative, the Kocher's incision? Why do that one?
Well, the right subcostal, or Kocher's incision, runs diagonally parallel to the lower edge of the right rib cage. To create this exposure, the surgeon must completely transect the right rectus abdominis muscle.
Wait, they literally cut through the six-pack muscle.
Yes, it is a significantly more traumatic entry. However, it offers exceptionally robust, wide-open access directly into that upper right quadrant. This is crucial for patients who are obese or who have a very deep, narrow chest cavity.
So if things are difficult.
Right. If a surgeon suspects a difficult gallbladder, perhaps that porcelain gallbladder we discussed earlier, they will gladly trade a wider scar for the uncompromised visibility and access provided by a Kocher's incision.
It's a calculated trade-off. Ease of recovery versus the immediate necessity of access. So, okay, the incision is made, we are through the abdominal wall, and the slide brings us to the next massive hurdle. Exposure. The instructions are very clear here. Use 2 Devers retractors to retract the liver. Then place an abdominal pack over the duodenum, stomach, and transverse colon and retract them inferiorly.
And this step right here separates a competent surgeon from a masterful one.
Really? Because it sounds like just moving stuff out of the way.
Well, getting through the abdominal wall is just carpentry, you know. What you do once you are inside requires immense finesse. As we discussed, the liver is a massive, heavy organ, but it is also highly vascular and incredibly friable.
Friable, meaning like it breaks apart or tears easily, like a block of wet sand?
A very apt comparison, yes.
Yeah.
Unlike the stomach or the intestines, which have a tough, muscular outer serosal layer, the liver is essentially a solid mass of delicate parenchymal tissue encased in a very, very thin capsule.
So you have to be gentle.
Extremely. If you try to lift the liver with a sharp or narrow instrument, it will slice right through the tissue like a wire through cheese, causing severe bleeding.
So that's where the Devers retractor comes in.
Right. A Devers retractor is a large, solid metal instrument shaped almost like a giant shoehorn. It has a broad, smooth, sweeping curve. It acts as a gentle, blunt cradle. It distributes the mechanical force over a wide surface area, which allows the surgical assistant to safely elevate that heavy liver edge superiorly up toward the patient's head without tearing the organ.
Okay, so with the liver lifted up, you still have to deal with the rest of the neighborhood. The slide mentions the duodenum, the stomach, and the transverse colon. I kind of picture this like preparing to renovate a room packed with delicate antique furniture.
That's a good way to look at it.
You have these vital sensitive organs crowding the surgical workspace, and you obviously don't want to accidentally puncture the colon with a scalpel later on. So you take an abdominal pack, which is essentially just a large, sterile cotton sponge, right?
Yes, exactly.
And you drape it over these organs. You are literally padding the furniture before gently pushing it inferiorly down toward the feet.
The furniture analogy holds up, but we must remember this furniture is highly reactive. The bowels do not like to be handled. Rough handling can lead to prolonged paralysis of the intestines after the surgery.
Oh, wow.
So the moist, soft abdominal pack acts as a protective buffer between the harsh metal of the retractors and the sensitive serosa of the bowel. By pushing the stomach and intestines inferiorly with the packs and simultaneously lifting the liver superiorly with the Devers retractors, the team creates a clear, isolated corridor of tension.
Everything is pulled tight.
Right. The tissues are drawn taut, and the surgical field is now fully exposed.
The stage is set, the protective padding is in place, the liver is held high, and the surgeon is staring directly into the anatomical abyss. Let's pull up slide 4. We are moving into section 3, navigating the danger zone.
Here we go.
The title of this slide is The Dissection of Callow's Triangle. The first operative step listed is to incise the peritoneum, covering the cystic duct and cystic artery, both anteriorly and posteriorly. Then you grasp the fundus of the gallbladder with sponge-holding forceps and retract its cephalad. And the slide specifically states this puts the cystic duct on a stretch.
Callow's triangle is arguably the most infamous anatomical landmark in general surgery.
Infamous.
Absolutely. It's a small geometric space bordered by three things: cystic duct on one side, the common hepatic duct on the other, and the inferior edge of the liver forming the roof. And inside this tiny triangle lies the cystic artery, which is the main blood supply we need to shut off.
Sounds straightforward enough.
In theory. But when a surgeon actually looks into the abdomen, they don't see a neatly drawn geometric triangle. The entire area is draped in a thin, translucent layer of tissue called the peritoneum, and the triangle itself is usually stuffed with fat, lymphatic tissue, and in disease states, thick, fibrous, inflammatory scar tissue.
The slide uses the phrase, skeletonizing the cystic duct and artery. That evokes a very specific visual for me. I imagine an archaeologist at a dig site.
Right.
You know there are fragile, vital structures buried under years of dirt and debris. You can't just take a backhoe to it. You have to take a tiny brush and meticulously dust away the peritoneal layer and the fat, teasing the tissue away millimeter by millimeter until the bare, skeletal, tubular structures of the duct and the artery are completely exposed and visible in 360 degrees. You have to trace the wires fully before you dare to bring in the wire cutters.
And the consequences of failing to be a meticulous archaeologist are severe. Which brings us to the urgent warning on the slide. Beware of variant anatomy of cystic duct and cystic artery.
Because it's not always where it should be.
Exactly. The biliary system is notorious for its refusal to follow textbook diagrams. The embryological development of the liver and bile ducts is incredibly complex, and that leads to a massive variety of structural anomalies. The cystic artery might branch off from its usual source, or it might originate from a completely different major artery altogether.
Just a total wild card.
And the cystic duct, rather than joining the main bile duct cleanly at an angle, well, it might run parallel and glued to it for a long stretch. Or it might even spiral completely around it before entering.
Wait, spiral around it? That's crazy. So if you don't trace it all the way out, you are just guessing.
And guessing leads to the most feared complication in this entire procedure. If a surgeon assumes a tube is the cystic duct without fully skeletonizing it, they might inadvertently place a metal clamp across the main common bile duct and slice it in half.
Which is devastating.
It severs the only pathway for bile to leave the liver and enter the intestines. It turns a standard 45-minute operation into a life-altering disaster for the patient, requiring complex, major reconstructive surgery.
Which perfectly sets up the absolute core philosophy highlighted at the very bottom of this slide. It's simply titled The Rule. Let me read it. The cystic duct is clearly defined only if you can make out the common hepatic duct, CHD, above the confluence of the cystic duct with the common bile duct, CBD, achieving the critical view of safety.
The critical view of safety. It is not just a suggestion. It is a universal surgical mandate formulated specifically to prevent those devastating bile duct injuries.
It's like a visual checklist.
A strict visual checklist that must be met before any cutting occurs. First, you must clear all the fat and fibrous tissue from callous triangle. Second, you must separate the lowest part of the gallbladder from the liver bed. And third, and most importantly, you must see exactly two and only two structures entering the gallbladder: the cystic duct and the cystic artery.
Let's go back to the physical action required to achieve this. The slide mentioned grasping the fundus, the wide top of the gallbladder, and pulling its cephalad up toward the head to put the duct on a stretch. Why is that physical distortion so crucial to achieving this critical view?
Because without traction, the ducts are slack, coiled, and often overlapping each other. They're a mess. By grabbing the gallbladder and pulling it firmly upward, the surgeon physically alters the three-dimensional geometry of the space.
Pulling the slack structures taut?
Exactly. By doing so, you pull the cystic duct away from the main common bile duct. You create a physical window of space between them. The rule states you must see the common hepatic duct continuing cleanly upwards, completely separate from the cystic duct.
And if you can't see that window?
If the area is a fused block of inflammation, and you cannot clearly see the space between these tubes, you do not have the critical view of safety. And if you do not have it, you absolutely must not cut.
Wow. It's a physical interrogation of the anatomy. You apply tension to force the hidden structures to declare their true identity. And only when the anatomy is laid bare, the dust is cleared, and the critical view is conclusively verified, do you proceed.
That's the moment.
That brings us to the definitive moment of separation. Let's advance to slide 5, entering section 4, the point of no return. This slide details the division protocols. First, the division of the cystic duct. After confirming the cystic duct, it should be divided. Distal part is suture ligated, and the proximal part simple ligature with vicryl. It also adds a conditional instruction here. If there is suspicious anatomy or a suspected common bile duct stone, perform an intra-op cholangiogram, an IOC. Then, the division of the cystic artery. It usually lies cephalad to the cystic duct, beware of variations, and ligate it as close to the gallbladder as possible.
All right, let's unpack the physics and the logic dictated on this slide. Starting with the cystic duct. The duct is the plumbing pipe. When we divide it, we create two ends. The proximal part is the side still attached to the gallbladder we are removing. The distal part is the stump that stays inside the patient, remaining connected to the main biliary tree.
Now, I am fascinated by the fact that the slide mandates two entirely different tying techniques for the two severed ends of the exact same tube. For the proximal part, the piece going in the trash, it calls for a simple ligature with vicryl. But for the distal stump staying in the patient, it specifically demands a suture ligature. Why the discrepancy?
It comes down to understanding the internal hydrodynamic pressure of the biliary system.
Okay, physics time.
Yes, a simple ligature is exactly what it sounds like. The surgeon takes a piece of vicryl, which is an absorbable synthetic braided thread, wraps it around the outside of the tube and ties a knot. It relies solely on the surface friction of the knot squeezing the tube shut.
Like tying a balloon.
Exactly. For the proximal part attached to the diseased gallbladder, a simple tie is perfectly adequate. We just want to prevent the infected bile trapped inside the gallbladder from spilling out into the clean surgical field while we work.
But the distal stump, the one staying inside the patient, is still connected to the active plumbing.
Exactly. The liver is constantly manufacturing bile, and the biliary ducts are a pressurized system. Every time a sphincter in the intestines opens and closes to receive bile, pressure waves rebound up into the ducts.
So it's constantly pulsing against that knot.
Right. So if you only use a simple friction-based tie on that remaining stump, there is a real risk that the constant internal fluid pressure could slowly push the tie right off the slippery end of the duct, much like a rubber band snapping off a tightly rolled piece of paper.
And if that tie slips off?
If that tie slips off, you end up with the 0.5% complication risk we saw on slide 2, a postoperative bile leak.
And bile leaking freely into the abdominal cavity causes a massive chemical peritonitis, right? It literally burns the tissues. So to prevent that, the slide dictates a suture ligature.
A suture ligature, which is also known as a transfixion stitch, physically anchors the knot. Instead of just wrapping the thread around the outside of the duct, straight through the center of the duct's tissue wall before wrapping it around and tying it.
Oh, wow.
Because the thread is mechanically woven through the cellular structure of the duct itself, it is physically impossible for the knot to be pushed off the end by internal fluid pressure. It is a structurally locked door.
It's tethered into the wall.
That is brilliant. Let's actually visualize this mechanical precision. I want to look at slide 6 and slide 7 in succession here, which provide incredible line diagrams of this process. As we look at slide 6, we see the instruments actively isolating the structures. You can clearly see the window of empty space in Callow's triangle that was created to achieve the critical view of safety.
It's beautifully illustrated there.
We see the metal jaws of the clamps completely crushing the duct to occlude the flow. Then, advancing to slide 7, we see the precise moment of ligation. The duct has been divided, and the suture lines are clearly visible on the remaining stump. Those visual diagrams perfectly capture the finality of the step. The clamping stops the fluid, the scissors make the permanent division, and the suture ligature secures the future. But notice the specific instruction regarding the cystic artery on slide 5. It says, ligate it as close to the GB as possible.
Right. We have to circle back to the terrifying reality of variant anatomy.
We do.
Why does proximity to the gallbladder matter so much when tying off the artery?
Because of a very common, very dangerous vascular anomaly known as Moynihan's hump, or sometimes called the caterpillar hump.
The caterpillar hump.
Yes. The right hepatic artery is a massive vessel supplying the right half of the liver. Normally, it stays well away from the gallbladder, but in some patients, it takes this tortuous looped detour. It loops down, closely hugging the neck of the gallbladder before turning back up into the liver.
Like a caterpillar inching along.
Exactly. Now, the much smaller cystic artery branches off for the peak of this loop. If a surgeon attempts to ligate the cystic artery far away from the gallbladder, they might accidentally clamp across the base of that massive right hepatic artery loop, believing it to be a long cystic artery.
And clamping the right hepatic artery cuts off oxygen to half the liver,
Leading to massive tissue death. Precisely. So, by forcing the surgeon to skeletonize the tiny cystic artery and trace it all the way until it is physically touching and sinking into the wall of the gallbladder itself, you guarantee you are at the absolute end of the line.
You leave no room for mistaken identity. You follow the wire right into the light bulb before you cut it.
Exactly right.
Now, the slide also mentions an IOC, an intraoperative cholangiogram, for suspicious anatomy or stones. What exactly happens there?
If the surgeon is ever in doubt about the anatomy, or if preoperative tests suggested a stone might have escaped the gallbladder and is currently wedged in the main common bile duct, they hit pause. Before cutting the duct completely, they make a tiny nick in it, insert a slender catheter, and inject a radiopaque liquid dye directly into the plumbing. Then, they use the X-ray table, which was specifically requested back on slide 2 to take a live fluoroscopic image.
So they light up the whole system.
Right. It provides a real-time illuminated map of the entire biliary tree. If the dye doesn't flow freely down into the intestines, it proves there is a hidden stone blocking the main duct, and the surgical team must pivot to address that blockage immediately.
Amazing. Okay, so the plumbing has been sealed and the electrical wiring of the blood supply has been cut, but the operation isn't over. The diseased organ is still physically cemented to the underside of the liver.
Yes, the extraction phase.
Let's move to slide 8, section 5, the extraction strategies. The slide gives the surgeon two distinct tactical approaches. The first is retrograde cholecystectomy. It involves cephalotraction of the gallbladder neck. Fibrous connections with the liver are divided by scissors, and hemostasis is achieved by diathermy.
That's the standard.
Right, but then the alternative is antegrade cholecystectomy, or the fundus first approach. The slide notes this is used when dissection in callus triangle is difficult due to dense adhesions. The gallbladder is dissected off the liver bed, beginning at the fundus.
This slide essentially describes the difference between a textbook operation and an advanced rescue maneuver. The retrograde approach is the standard. Retrograde implies moving backwards or from bottom to top. Because you have just successfully divided the duct and the artery right in the bottom neck of the gallbladder in callus triangle, you use that freed neck as a handle.
Ah, clever.
You grab it, pull it cephalad upward and away from the liver, and begin mechanically separating the gallbladder from the liver bed, working your way up to the wide dome-shaped top, the fundus.
It sounds a bit like unzipping a jacket from the bottom up. You've separated the bottom clasp, and now you are applying upward traction to smoothly pull the two sides apart. But the slide notes the use of scissors for dividing the fibrous connective tissue, and it also dictates hemostasis achieved by diathermy. Now, I understand using scissors to cut physical bands of scar tissue, but what is the physics behind diathermy in this specific context?
As you peel the gallbladder off the liver bed, You are exposing a raw, weeping surface of liver parenchyma.
Because they were essentially glued together.
Right. The liver bed is laced with thousands of microscopic capillary channels. You cannot possibly take a needle and thread to tie off every single oozing capillary. It would take hours and cause way more damage. So diathermy is the application of a high-frequency alternating electrical current. The surgeon uses a specialized wand that looks almost like a metal pen. When the metal tip touches the bleeding liver tissue and the surgeon steps on a pedal, the electrical current passes into the tissue. The high frequency of the current creates rapid cellular oscillation, generating intense localized thermal energy.
It literally boils the tissue on a microscopic scale.
It denatures the cellular proteins and causes the blood vessels to instantly shrink and coagulate. It allows the surgeon to physically burn away the attachments while simultaneously stopping the capillary bleeding. You're achieving hemostasis in real time as you dissect.
Let's actually visualize that tool at work. We will bring up slide 9 and subsequently slide 10. Slide 9 gives us a line diagram of the diathermy wand in action. You can see the pen-like tool actively burning away the fibrous attachments. But what's crucial here is the direction of the dissection in the drawing. The diathermy is starting at the wide top, the fundus, and working its way downward.
Yes, beautifully observed.
This illustrates the second strategy listed on slide 8, the antegrade or fundus-first approach.
And the antegrade approach is really the hallmark of a surgeon who knows how to adapt when the textbook fails. Let's say a surgeon opens the abdomen and looks at Callot's triangle, but instead of seeing distinct structures they can skeletonize, they just see a frozen block of inflamed, cemented scar tissue. The gallbladder is welded to the bile duct and the duodenum.
A total mess.
Right. Trying to aggressively dig into that mess to find the cystic duct is a guaranteed way to cause a catastrophic injury.
Because you can't achieve the critical view of safety.
Exactly. So you abandon the standard bottom-up retrograde approach.
Yeah.
You move to the top of the gallbladder, the fundus, which is usually much further away from the dangerous anatomy of the bile ducts.
So if retrograde is unzipping the jacket from the bottom, the antegrade approach is realizing the bottom zipper is completely rusted shut. So you grab the collar and pull the entire sweater over your head from the top down.
Fantastic analogy, yes. You start peeling the gallbladder off the raw liver bed from the top, working your way down toward the neck.
And the advantage of that is what?
The brilliant tactical advantage is that by peeling it downward, you eventually approach that cemented callous triangle from behind, from a completely inverted anatomical angle.
Oh.
Often, this 180-degree change in physical perspective allows the surgeon to clearly identify the cystic duct and artery from the backside, allowing them to isolate and divide those structures safely as the absolute final step of the organ's removal rather than the very first.
That is so smart. And as we transition our view to slide 10, we see the culmination of either strategy. The diagram shows the gallbladder completely mobilized, hanging by its final threads, ready to be lifted out of the body.
It is a profound visual, an infected organ entirely isolated from the host.
But a master surgeon's focus doesn't end when the specimen hits the metal basin.
Actually not.
The environment they leave behind inside the patient is just as critical as the organ they removed. Let's turn to slide 11, section 6. Securing the liver bed. The top half covers hemostasis of the GP bed. It reiterates that separation is done piecemeal, but it adds a critical protocol. Uncontrolled bleeding stopped with local compression, suturing, or Surgicel.
Right, because once the gallbladder is extracted, the surgeon's attention shifts entirely to the gallbladder bed. That's the raw, exposed crater left behind on the underside of the liver.
And it's still bleeding.
Well, despite the careful use of thermal diathermy during the dissection, this large surface area can still ooze significant amounts of blood, especially if the patient's liver is inflamed. The slide dictates a tiered approach to stopping this bleed. The first line of defense is the simplest: local compression.
Just putting pressure on the wound.
Yes. The surgeon will take a warm, moist surgical pack, press it firmly against the raw liver bed, and simply hold it there for several minutes. They are buying time, allowing the patient's own intrinsic physiological clotting cascade, the platelets and fibrin, to activate and seal the microscopic leaks naturally.
And if that doesn't work?
If they remove the pack and see a specific, larger vessel actively pulsing blood, they will move to the second tier, suturing it precisely with a delicate needle.
Okay, but the slide lists a third option for uncontrolled bleeding: Surgicel. What is the science behind Surgicel?
Oh, Surgicel is a remarkable piece of biochemical engineering. It is an oxidized, regenerated cellulose matrix. When you open a sterile pack of Surgicel, it looks and feels remarkably like a sheer, loosely woven piece of cotton gauze or fabric.
Like cheesecloth.
Yes. When a surgeon encounters diffuse, stubborn oozing from the liver bed that just won't respond to pressure or diathermy, they lay a sheet of this fabric directly onto the raw, wet tissue.
But wait, isn't leaving a foreign fabric inside the abdomen asking for a massive immune response or an infection?
That is the absolute genius of its design. When Surgisil comes into contact with blood, it physically swells and turns into a dark, gelatinous mass. This sticky matrix provides an immediate, massive, physical scaffold for the patient's circulating platelets to crash into and adhere to.
So it's basically a net.
Exactly.
Yeah.
It artificially accelerates the formation of a robust blood clot across a wide surface area. It acts as an artificial scab. And to address your point about leaving it behind, the cellulose material is completely bioabsorbable.
Oh, it dissolves.
Yes. Over the course of a few weeks, the body's enzymes will naturally break it down and reabsorb it without a trace.
A bioabsorbable scaffolding that weaponizes the body's own clotting mechanisms. That's incredible. Now, let's look at the second half of slide 11, which deals with drainage of the GD bed. After hemostasis is achieved, the surgeon must inspect the stumps of the cystic duct and artery, and then the slide offers a very specific instruction. Consider subhepatic drain only in complicated cases with lot of dissection for extensive adhesions.
Very important wording there.
To visualize this, let's simultaneously look at slide 12. Slide 12 is a clear line drawing of the empty liver bed, but lying right in the middle of the surgical space is a physical perforated plastic drain tube. Why does slide 11 put so much aggressive emphasis on the word only in complicated cases?
That capitalized only represents a massive paradigm shift in modern evidence-based surgery. If we rewind a few decades, placing a surgical drain, a silicone tube left inside the abdomen that exits through a small hole in the skin to constantly siphon fluid into an external bulb, that was considered mandatory standard operating procedure for almost every open cholecystectomy.
The logic makes intuitive sense, though. You just operated on a major organ, there might be a tiny undetected bile leak or some residual bleeding. Better to have a dedicated escape route to pull that fluid out of the body than let it pool inside, right?
That was the prevailing historical dogma. The drain was seen as a safety valve. However, as surgical data sets grew, massive retrospective studies revealed a contradictory truth. Routine prophylactic drainage was not preventing complications, it was actively causing them.
Wait, really?
A drain is fundamentally a two-way street. Yes, it can pull fluid out, but it is also a physical piece of plastic breaching the sterile fortress of the abdominal cavity, connecting it directly to the non-sterile outside world.
Oh, a highway for bacteria.
Exactly. Drains act as a highway for skin bacteria to migrate inward, significantly increasing the rate of intra-abdominal infections.
Oh.
Furthermore, the physical presence of the plastic tube irritates the surrounding bowel, causing pain and delaying the return of normal intestinal function.
So, routine drainage was actually sabotaging the patient's recovery.
Precisely. Therefore, the modern surgical mandate, as clearly reflected in Dr. Selvaraj's presentation, is that if you have a clean, dry field, and you have visually confirmed that your transfixion sutures on the duct and artery are rock solid, you do not place a drain. You trust the human body's vast peritoneal surface area to easily reabsorb any minor normal physiological fluid shifts.
You only deploy the drain in the nightmare scenarios, the cases with extensive adhesions where the surgeon had to spend 2 hours aggressively scraping, tearing, and burning a massive area of the liver just to get the gallbladder out.
Yes.
In those highly traumatized cases, the liver bed is guaranteed to weep a massive volume of inflammatory fluid and blood, and the benefit of evacuating that heavy fluid load finally outweighs the risk of the tube.
Exactly. The drain has transitioned from a routine habit to a highly selective, calculated intervention.
Amazing. Okay, the field is dry, the biological scaffolding is in place, the duct and artery stumps have been double-checked, the decision on the drain has been made, the destructive phase of the surgery is complete, and it is time to transition to the reconstructive phase. Let's pull up slide 13, section 7, the road to recovery.
The final stretch.
The slide details the closure first. Coutures or ART, upper transverse abdominal incision closed in layers. Then we move to post-op care. We remove the NGT, the nasogastric tube on day 1, and the drain, if present, on day 2 or 3. Diet. Oral fluids after 4 hours progress rapidly to semi-solids, then solids.
Very aggressive timeline.
And the physical mandates. Ambulate the patient immediately, and incentive spirometry or chest physio in the post-op period. Finally, advice rest from work for 7 days.
This single slide encapsulates the entire philosophy of ERAS-enhanced recovery after surgery. It is a scientifically optimized protocol designed to mitigate the profound physiological stress response the body undergoes after major trauma.
Let's analyze the closure instruction first.
Hmm.
Closed in layers sounds simple, but I'm guessing it is structurally vital.
Oh, extremely. The human abdominal wall is not a single homogeneous piece of meat. It is a highly engineered biological retaining wall composed of distinct anatomical strata.
Right, you have the inner lining, the muscle, the fat, and the skin.
The surgeon must systematically reconstruct that wall from the inside out. They first sew the thin peritoneum closed. Then, and most importantly, they use heavy, strong sutures to meticulously pull the tough fascial layers of the abdominal muscles back together.
The fascia.
Yes, the fascia provides the true mechanical tensile strength of the abdomen. If the surgeon rushes this step and just grabs all the tissue in one massive, imprecise bite, the layers won't heal properly.
What happens then?
Well, months later, the internal pressure of the intestines can push through that weak spot, creating an incisional hernia that requires another surgery to fix. Closing in distinct anatomical layers restores the architectural integrity of the core.
You have to rebuild the wall brick by brick. But looking at the postoperative instructions, what truly staggers me is the sheer speed of the timeline. We literally just performed a major open abdominal surgery. The surgeon physically handled the intestines, lifted the liver, and amputated an organ. Yet the slide mandates introducing oral fluids just 4 hours after the operation and ordering the patient to get out of bed immediately.
Seems counterintuitive, doesn't it?
It does. Isn't the body begging for rest to heal?
That is exactly what surgeons believe for the first half of the 20th century. Patients were kept strictly nil pares nothing by mouth for days, with tubes sucking their stomachs empty, and they were confined to strict bed rest. But physiological research proved that enforced rest is incredibly toxic.
Toxic. How?
Let's look at the gastrointestinal tract. When a surgeon's hands or metal retractors touch the sensitive intestines, the bowel reacts defensively by freezing. The smooth muscle contractions that move food along peristalsis, they completely stop. This paralysis is called a post-operative ileus.
If the plumbing is paralyzed, you can't digest anything and gas builds up.
And prolonged fasting only signals the bowel to stay asleep. The fastest way to break an ileus and wake the intestines up is to give them a job to do. By introducing clear oral fluids a mere 4 hours after surgery and rapidly escalating to solid food, the team is sending a powerful physiological chemical signal down the gut.
It's like flipping the power switch back on.
It triggers hormonal cascades that force the smooth muscle to resume its normal rhythmic contractions. You are literally kickstarting the digestive engine.
And what about the mandate to ambulate the patient immediately? I mean, forcing someone with a fresh 6-inch abdominal incision to stand up and walk sounds agonizing.
It requires immense pain control and coaching, but it is non-negotiable because it is a matter of life and death. Lying flat and immobile in a hospital bed is highly unnatural. It triggers a dangerous cascade known in medicine as Virchow's triad.
Virchow's triad. Okay, break that down.
First, blood flow in the deep veins of the legs slows down drastically, pooling in the calves due to gravity and lack of movement. This is called stasis. Second, the surgery itself caused tissue injury. And third, the body's systemic response to that trauma creates a hypercoagulable state, meaning the blood naturally wants to clot to stop bleeding.
Stasis, injury, and thick clot-prone blood. That's a recipe for a deep vein thrombosis, a DVT.
Exactly. A massive blood clot forms in the leg vein. If a piece of that clot breaks off, it travels straight up through the heart and slams into the pulmonary arteries of the lungs, causing a pulmonary embolism, which can be instantly fatal.
That's terrifying.
It is. But when you force a patient to stand up and walk, the physical contraction of their large calf muscles acts as a secondary heart. It actively pumps that pooled venous blood forcefully back up to the chest, physically preventing the stagnant conditions required for a DVT to form.
The walking also connects to the next directive on the slide, incentive spirometry or chest physio. We have to think back to slide 2, the setup. The patient was paralyzed under general anesthesia with an endotracheal tube pushed down their throat while a mechanical ventilator forced air into their lungs for an hour.
The pulmonary system takes a massive hit during upper abdominal surgery. Under general anesthesia, the tiny balloon-like air sacs at the very bottom bases of the lungs often collapse completely, a condition called atelectasis.
And because it hurts to breathe.
When the patient wakes up, they have a large, painful incision just inches below their diaphragm. It hurts immensely to take a deep breath. Human instinct dictates that the patient will take very shallow, rapid, guarded breaths to minimize the tension on their abdominal wound.
But shallow breathing means those collapsed air sacs at the bottom of the lungs never reinflate.
And collapsed, stagnant lung tissue is the perfect, warm, dark breeding ground for bacteria. Before early mobilization protocols, postoperative pneumonia was a massive killer of surgical patients. This is where the incentive spirometer comes in.
The plastic tube with the little ball inside.
That's the one. It is a clear plastic medical device with a mouthpiece and a visual gauge, often a floating ball. It forces the patient to change their breathing mechanics. Instead of passive, shallow breathing, they must actively suck in air slowly and deeply, generating sustained negative pressure to lift the ball and keep it hovering.
It's physical therapy for the respiratory system. It forcefully expands the chest cavity, tearing open those collapsed alveoli and forcing oxygen back into the deepest lobes of the lungs, effectively preventing the environment pneumonia needs to thrive.
This entire slide, the immediate eating, the forced walking, the deep breathing exercises, it demonstrates that modern surgical recovery is an aggressive, active, athletic event. It demands immense participation and willpower from the patient, carefully guided by the surgical and nursing team.
Which leads to the final point. Advice: rest from work for 7 days.
It highlights the culmination of this ER's protocol. By aggressively preventing the secondary complications of ileus, blood clots, and pneumonia in the first 48 hours, a patient can return to a functional, relatively normal life just a week after having a major organ extracted from their abdomen.
It is a remarkable testament to the resilience of the human machine when properly managed. Which brings us to the final stage of our journey today. As we transition to slide 14, our final slide, we see a visual thank you screen, complete with prominent visual prompts to like, share, and subscribe.
Yes, the classic YouTube sign-off.
Right. But for our masterclass students listening and mentally visualizing this entire process, if this detailed rehearsal helped clarify the complex three-dimensional chess game that is an open cholecystectomy, we highly encourage you to interact with those buttons on Dr. Selvaraj's platform. Like, share, and subscribe to the Surgical Educators content to continue expanding your mental operative atlas.
And before we sign off, I want to leave our students with one final philosophical thought to mull over. We've just spent a significant amount of time meticulously walking through the standard formalized steps of this procedure. We've mapped out the textbook approach to callus triangle, the definitive rules of the critical view of safety, and the standard recovery timelines.
The blueprint.
The blueprint, exactly. But despite being a fundamental operation taught very early in surgical training, the open cholecystectomy remains one of the ultimate tests of a surgeon's true clinical adaptability.
Because the anatomy is never guaranteed.
Precisely. The constant looming threat of variant anatomy and the unpredictable nature of inflammatory scarring means that no two biliary surgeries are ever truly identical. This procedure serves as a profound daily reminder that in the demanding discipline of surgery, knowing the standard, bulleted protocols is only half the battle.
You have to read the room, or rather read the patient.
That academic knowledge must always invariably be paired with a hyper-vigilant observation of the unique, living human landscape laid out before you. A master surgeon must always pause and question if what they are looking at in the operative field is exactly what they think it is, before they ever close the jaws of a clamp or make a definitive move with a scalpel.
You've run the mental movie. You've walked through the complex anatomy, the internal physics, the mechanical tactics, and the physiological recovery. Now it is time to take that hard-earned knowledge and that unshakable confidence directly into the OR.